Okay, good evening. Should I start or Vivek, you are going to say a few words?
So please, sir, I welcome all for this expert group meeting. It's my privilege, Dr. Shyam Agarwal, sir, who is the program director, to please, take it forward. Thank you.
Okay, so thank you very much. This is an Eisai expert group meeting on RCC, and we have a fairly busy program lined up under the chairpersonship of Dr. Professor P.K. Julka and Dr. J.S. Sekho. We'll be privileged to see Dr. Sekho after a long time. I have not seen him, so I welcome him as the chairperson there. So just to say that there are going to be three talks, 15 minutes each, and followed by a panel discussion. And this is all focused on kidney cancer, that too in the metastatic setting. So I'll request Dr. Julka and Dr. Sekho to introduce the speakers and take it forward, please.
Good evening.
I'll request Dr. Julka to do the honors. Senior person, more senior person over here.
Yes.
Good to see you, GS.
Good evening, sir.
Yeah.
Good evening, sir.
Sure.
So good evening, everybody. Let us start with the first talk, nephrectomy versus no nephrectomy in advanced, that is metastatic RCC, by Dr. Dipanjan Panda. Dr. Panda needs no introduction to this audience. So Dr. Dipanjan, please.
Thank you, sir. Thank you, Dr. Julka, sir, and Dr. Shyam Agarwal, sir, and Dr. Sekho, and Dr. Somani. And they're all seniors, and it is an honor and privilege. There are 26 slides. I think most of the things are known. This is an expert group, but since I have been given this task, I will nonetheless, you have to bear me for 15 minutes. Am I visible? Is the slides visible?
Yes, go ahead. We can see.
Okay. So this is the schema of presentation. I will briefly tell you of the current role of surgery in RCC, pro and cons of nephrectomy in advanced RCC. And I will also briefly discuss the Carmina trial, which is the cytoreductive nephrectomy followed by sunitinib versus sunitinib alone in patients with metastatic RCC. And I'll also briefly discuss the consideration for nephrectomies and advanced RCC. So if we consider that current standard of care for localized RCC is surgery, and we all know the surgical options include radical nephrectomy or a partial nephrectomy. A radical nephrectomy basically involves a periphyseal resection of the whole kidney along with perirenal fat and regional lymph node. Also, its lateral adrenal gland. It may be omitted, but it usually is taken into. And radical nephrectomy is standard of care in patients with stage 2 and 3 renal tumor in TNM classification. Also in stage 4 with a T4 direct extension to the ipsilateral adrenal gland if there is no other evidence of disease, or a oligometastatic or a disease, whether resectable primary RCC and solitary resectable metastatic site, then we consider radical nephrectomy. They can also sometimes lead to increased risk of CKD, and sometimes it has been seen that can be increased risk of cardiovascular mortality and morbidity. Partial nephrectomy and nephron sparing surgery, where surgery removal of the tumor is done along with thin rim of normal tissue and part of the kidney is spared. They are usually done for a selected group of patients, namely a patient having small unilateral tumor, and of course the patient who are not suitable for, these are not so locally advanced tumor. In these cases, preservation of renal functions is the cases where it's crucial. Then we prefer partial nephrectomy, like patient having a single kidney, a patient having renal insufficiency, bilateral renal tumor, and patients with an hereditary form of RCC such as chronic Penn-Lindau disease. So if we can just think of the surgical management as per the stage is concerned, for stage 1, we can do partial nephrectomy, but we can also do radical nephrectomy. For stage 2, the radical nephrectomy is preferred, and only in selected cases we do partial nephrectomy. So in stage 3, where radical nephrectomy is preferred, and stage 4 M0 we do radical nephrectomy, as well as stage 4 with M1. If we can do a good metastatectomy, we can do a radical nephrectomy. According to the TNM classification, if you think of the partial nephrectomy is appropriate in patient with small unilateral tumor. We have already discussed where preservation of renal function is a primary issue, such as patient is having one kidney or those with renal insufficiency, bilateral renal masses, or familiar RCC. You can also do an ablation, but we know that ablation therapy is associated with increased risk of local recurrence because the margin is not clear. So if you have to do therapy, the partial nephrectomy is a preferred option compared to ablative therapy. Sometimes active surveillance is an option for management of localized renal mass, but it should be a primary consideration for patients who have decreased life expectancy or having an extensive comorbidity that will place them at an excessive risk. As I mentioned, that for patients who have a disease which is localized but can extend into inferior vena cava, we can do a radical nephrectomy and thrombectomy. And we have done, and we all do see cases where they are into in IVC. You can go up to the even right atrial thrombus. You can actually take them out in total, but sometimes you may require a CTVS surgery. But the problem is that when there is an infiltration of the tumor thrombus into the wall, then you cannot do the surgery. And sometimes, because if it is too long, then even a venous graft is not possible, and you have to leave that, and that will be treated as a unresectable disease or a metastatic disease. Partial nephrectomy may be performed in patient with locally advanced tumor if technically feasible and clinically indicated. Anyway. A brief discussion on the neoadjuvant therapy for stage 4 disease. Prospective studies actually have not established a definitive role for NACT in RCC. There was one paper way back in 2014 where a single institution phase 2 trial was done. They used neoadjuvant axitinib in patient in non-metastatic stage 4 RCC. And the trial included patients that were candidate for radical or partial nephrectomy. Patient had a locally advanced non-metastatic T2 or T3B clinical disease, and they received axitinib for 12 weeks. The primary endpoint was overall response. The median reduction of primary renal tumor diameter was 28.3%, and partial response was about 45%. About adjuvant therapy, we all know for years there have been multiple studies with sunitinib as well as sorafenib. I think out of all these studies, this is an old slide. These studies have actually completed, and this ACE-TRACT study did show there is some improvement in adjuvant sorafenib. However, adjuvant pazopanib did not reach the clinical significance. So the adjuvant trials among the drug, only sunitinib is approved, but it is done on a very limited and this group of patients. What about the surgery for metastatic RCC? Now, since about a couple of years back, I think cytoreductive nephrectomy was one of the standard of care, that is tumor debulking prior to systemic treatment. It was also included in the guidelines, including NCCN. And the reason for this, there was 2 randomized trial of nephrectomy followed by interferon alpha versus interferon alpha alone, and it improved in overall survival. There was also a non-randomized retrospective study which compared the patient who had got some targeted therapy and did not compare with the patient who did not receive nephrectomy, and nephrectomy associated with improved overall survival, but this was a non-randomized retrospective study. And so if we think of surgery for metastatic disease, then patient selection criteria is important, where we should consider for the prognosis of the patient, radiology feature of the primary tumor and the extent and position of the metastasis, and what are the systemic treatment options available. And metastatectomy in the resection of disease, in metastatic disease, should be considered for patients who have limited metastatic disease, limited tumor burden, and a good DFS, that is 1 year or more. And a patient who undergo a complete resection of metastatic disease ideally should be managed with surveillance. So if we look at the pro and cons of nephrectomy in metastatic renal cell carcinoma, I think the advantage of nephrectomy is the control of symptoms for primary tumor, and that is still a good reason. If the patient is having hematuria, severe pain, then doing nephrectomy can improve the symptom control. You can also say there are few old phase 3 trials which showed that there are always benefit. Of course, most of the trials are pre-targeted therapy era. There is also a theoretical advantage of resection of resistant clone, and a majority of the clinical trial patients was having nephrectomy. But also there are problems with complication of surgery, no benefit proven with targeted therapy. There is delay of systemic therapy if post-surgery complication happens, impaired treatment adherence, increased risk of hypertension, and comorbid patients with comorbidity are unlikely to benefit. So if you can see, this is the pre-targeted therapy treatment where the nephrectomy did show overall benefit. But if you look at this study, all those phase 3 trial and meta-analysis was with interferon alpha. And the only targeted therapy related trials are all retrospective. So it was overdue to see how debulking surgery or a nephrectomy improves overall survival in the targeted therapy era. So this is one of the pivotal trial, Carmina trial, published in NEJM, a cytoreductive nephrectomy followed by sunitinib versus. I think I have 2 minutes, 3 minutes left, sir. So Carmina trial, so background of Carmina trial is that, as I've told, that cytoreductive nephrectomy has been associated with standard of care of metastatic renal cell cancer based on trial data showing greater benefit of nephrectomy, and multiple clinical trials have shown efficacy of targeted therapy, and no head-to-head comparison before that was done of nephrectomy with targeted therapy versus targeted therapy, and there was only retrospective data, and which included that IMDC data that included nephrectomy with targeted therapy was beneficial with a less than 4 IMDC prognostic factor. So this was a phase 3 randomized open label non-inferiority trial where adult patient with biopsy confirmed clear cell RCC and ECOG having good PS status 0 to 1 without recurrence, and also treated brain mets without recurrence 3-week post-treatment. They was permitted and suitable candidate for nephrectomy, eligible for sunitinib, no prior systemic therapy. Total 450 number of patient. Primary endpoint was overall survival. Randomized to nephrectomy followed by 6 weeks later sunitinib, 50 milligram OD, 4 weeks on, 2 weeks off, standard, 226 patient versus sunitinib 50 milligram per day, 4 weeks on, 2 weeks off, with a follow-up of minimum 2 years. The primary endpoint was OS, trial designed to have 80% power with on-site 0.05 and show non-inferiority with 576 patient. And observed death was about 456. The second endpoint was progression-free survival, overall response rate, clinical benefit as per the treating physician, treatment adherence, nephrectomy in sunitinib, only arm. Of course, mortality, morbidity, and safety. So they are more or less well matched, nephrectomy and plus sunitinib versus sunitinib alone arm, except if you can see that in nephrectomy arm, the T3, T4 disease were more, about 70% versus 50% in sunitinib only arm. And if you look at the nodal disease, I think the N2 disease was more in sunitinib arm. The rest of the data, I think, are fairly evenly matched. Now, without wasting much time, I'll just come to the overall survival data. So they've proven that the overall survival in the sunitinib alone arm was significantly higher. It was 13.9 months in the surgical arm versus sunitinib alone arm was 18.4 months. So it was definitely sunitinib alone was not inferior to nephrectomy. And median overall survival was sunitinib alone was longer. And even in, especially in even more stark in intermediate and poor risk. And also there was improvement in PFS in sunitinib alone arm, and it was 7.2 in the surgical arm versus 8.3 in the sunitinib alone arm. The ORR was almost similar. The disease control rate was superior in the sunitinib alone arm, and the clinical benefit was also superior in sunitinib arm. So, about the safety and nephrectomy outcome, in nephrectomy followed by sunitinib arm, 95% patient underwent nephrectomy, with most having open surgery. There was post-op mortality was on 2%, post-op morbidity was 39%, and sunitinib alone arm, 38 patients ultimately needed secondary nephrectomy. So what are the major conclusions with Carbina? So the sunitinib alone is not inferior to cytoretic nephrectomy. Hazard ratio for death was 0.89. Median OS longer. Clinical benefit rate is significantly higher with a p-value is 7.02. So the investigator concluded that nephrectomy should no longer be part of standard of care of metastatic RCC required medical treatment. Now there are a few factors which need to be considered, as that non-clear cell histology was not in this trial. So, and we all know they have suboptimal systemic therapy option, and I think cytoretic nephrectomy is still a valid option in non-clear cell histology. Patient performance status, which also an important factor, because retrospective studies have shown that patients with impaired performance status fail to benefit from cytoretic nephrectomy. And a delay in systemic therapy because of cytoretic nephrectomy is a concern for symptomatic patient RCC. Patient with a liver mets and nodal involvement likely to have a higher complication with nephrectomy and should be avoided. MSTCC risk criteria or benefit shows that the poor risk patient does not benefit from cytoretic nephrectomy. So if you can, in one slide, I can tell that if patient has a minimum external disease, PS0, nephrectomy makes sense. Intermediate risk, moderate external disease, it may or may not be indicated, and a tumor board can decide. But even the last slide, if the poor PS, poor risk, large primary, extensive external disease, in today's era, I think nephrectomy does not really make sense. So with this, I thank you all, and I conclude, and I'm sorry for having outlined. Thanks.
Thank you, Dr. Panjan. We'll have questions at the panel discussion. So I think I would invite Dr. Naresh Somani to tell us about the first-line treatment options in metastatic renal cell carcinoma. Dr. Naresh, please.
Sir, good evening and thanks to the chairpersons. May I request to share my, can someone put my slides here?
Sure, sir. I'm just doing it.
Yeah. So I have been assigned the first line treatment in the advanced or the metastatic RCC. So I will be basically limiting myself to the clear cell histopathology, and the issues presently in the advanced metastatic RCC is what is the role of the surgery as being discussed by the Dr. Panda just now, and when to treat the patients and what sort of the drugs, single agent TKI or the combination of the drugs, and on what factors or the risk stratification you want to choose your patient. So coming to the next slide. Next slide, please.
Yes, I have done it. Just a timeline.
Yeah. So can I do it myself, or you need to do it?
I'll do it, sir. I'll do it, sir.
So can we go to the next slide, please? Next slide, please. Dr. Vivek, next slide, please. Yeah. So presently, most of the patients are being stratified based on the IMDC criteria for the metastatic RCC. It's a very simple, based on the simple parameters like the time from the initial diagnosis to the treatment start, 1 year or less than that. Performance status, that is the based on the CBC, hemoglobin, platelet, neutrophils, and the calcium. Based on these parameters, 6 parameters, we categorize the patient in the favorable risk, intermediate risk, and the poor risk. For the treatment purpose, intermediate and the poor risk patients are most of the time being clubbed versus the favorable risk patients. Next slide, please. We need to keep in the mind that most of the patients presently in Indian setup are falling in the intermediate or the high risk patient. And this slide shows very clearly that why it is so important to categorize the patient before you start the treatment. We can see that since the very beginning, these 3 categories of the patient, they start separating from each other as far as their prognostication is concerned. Next slide, please. So another important point is that presently the various drugs which are available, the pathways which are being understood, and how these pathways are being manipulated or being utilized for the treatment of the metastatic RCC. The most important thing which we understand presently is the VEGF pathway, and the other way to understand is the that is the mTOR pathway and the PD-1, PD-L1 inhibition, and the role of the immunotherapy or the immune pathways in the metastatic RCC. Next slide, please. Next slide, please. So another important thing, presently, most of the newer treatments and the newer clinical trials which are coming are certainly based on the more than one drugs. That is basically the doublet. Now, this doublet may be presently the combination of the IO plus IO. It may be the combination of the IO plus TKI, or it may be the TKI plus mTOR pathway manipulation. Now, there are rationale for combining IO plus IO different ways. This logic is not only for the NSCLC and few other malignancies. It applies in the RCC also. The concept remains the same. That is the presently the available drugs are, that is the PD-1 inhibitor with the CTLA-4 blockade pathway. We combine the 2 drugs. The most common drugs which are being used for this is the nivolumab plus ipilimumab. Next slide, please. And similarly, there are the rationale in the metastatic clear cell RCC, that is the combining the VEGF pathway inhibitor drugs and the PD-1 or the PD-L1 inhibitor drug. Now, this theoretically says to us that this is not 1 plus 1, rather it is more than 2. And once we do this pathway inhibition, we understand that VEGF inhibition may reduce the number of the T regulatory cells in the tumor invading myeloid-derived suppressor cells. And now this becomes the rationale for combining them with the immune checkpoint inhibitors and giving them more and more response rate and more improvement in the progression-free survival and possibly overall survival also. Next slide, please. Now, Carmina trial, that is the important concept, nephrectomy versus non-nephrectomy, has been just discussed and has been clearly shown to us that which are the patients which we need to select for the nephrectomy. Now, important question which has now come up, that what is the role of the nephrectomy for those patients who will go for the immune checkpoint inhibitors in the first line versus in the second line versus the first line in combination with the TKI plus immune checkpoint inhibitor. So this point, because now this is a new situation, so nobody has an answer that what is the role of the nephrectomy in the sunitinib era versus in the immune checkpoint inhibitors era. Next slide, please. Next slide, please. Next slide. Next slide, please. Next slide. So presently, the conventional first-line treatment which we are using, at least for the last 1 decade, that is the sunitinib. It shows the improvement compared to the interferon. Remains the standard of care, sunitinib or pazopanib, for long time with us. Bevacizumab plus interferon, though it was approved with the category 1 level of the evidence, but this did not pick up because of the IV preparation, because of the cost and the logistics and the other reasons. And poor risk patient, yes, temsirolimus is the drug, but most of the time it is not being used, at least with our setup. Next slide, please. So the changes came when we understood the pathways, when we had the immune checkpoint inhibitor drugs, when we had the more strong drugs like cabozantinib or lenvatinib. So the important landmark trials which came with the help of the cabozan trial, that is the cabozantinib, and it showed the benefit compared to the sunitinib. Another trial was the Nivo plus Ipi combination. Another trial was the IM Motion 151, that is the atezolizumab PD-L1 inhibitor plus bevacizumab. And the important trial came with the help of the pembrolizumab with the TKI, that is the axitinib in the first line, and the javelin, that is the avelumab plus TKI, that is again the axitinib. Can I request everyone to please mute their mics? Now, these trials has shown first time to raise the bar of the response rate more than 50%. Now, any situation in the metastatic RCC, especially my seniors, Dr. Julka and Dr. Shyam Agrawal, they will agree that in the difficult malignancy like metastatic RCC, having a response rate more than 50% in the first line is really matter of great satisfaction. And this could now be achieved with the various immune checkpoint inhibitors in combination with the TKI. Next slide, please. Next slide. Yeah. So cabozantinib, I will not pay much attention here because this drug presently is not available. But yes, it is approved first line because it has shown better response compared to the sunitinib. Next slide, please. Next slide. Yeah. Next slide, please. And another concept is the frontline IO in RCC therapy. The various phase 3 trials, we know about the success story, the Ipi plus Nivo versus sunitinib. We know about the keynote 426, that is the Pembro plus axitinib. And I am sure that most of our patients are being counseled presently for the Pembro plus axitinib, especially in the intermediate or the high risk, if the cost is not the factor. And yes, Nivo plus cabozantinib trial is also there, shown the overall survival benefit, but cabozantinib presently not available with us. Avi plus axitinib, again similar trial compared to the Pembro plus axitinib, but Avi presently is not available in India. And another trial which is now shown the PFS benefit, though the approval is not there, that is the atezolizumab plus bevacizumab combination. But this trial, important thing is that it is based on the PD-L1 stratification. Now Pembro plus Lenva versus sunitinib, this trial is completed and we hope that the results will be coming very soon. And I am quite sure that looking at the potentiality of the lenvatinib, the response rate in the second line, especially in combination with the mTOR inhibitor, maybe that Lenva plus Pembro may replace the Pembro plus axitinib as the front line, or maybe in the subsequent line of the treatment. Next slide, please. Now, checkmate 214 Nivo plus Ipi, again the stratification was based on the various routine conventional parameters which we do. And here important thing is that the 4 doses of the combination are being given, and then subsequently the single agent Nivo is being given, something like the NSCLC. And these 2 drugs now are on the horizon of the Indian market. So maybe that this combination will also catch up for our patients also, and this trial also has shown the benefit in the first line treatment. Next slide, please. So this is how this combination of the IO plus IO is better than the sunitinib. The important point here to highlight is that the graphs started separating quite early, just at the end of the 6 months. So there is a more response rate, there is a more progression-free survival, and there is a more overall survival in the intent to treat population. Next slide, please. So this is how we can see when we stratify these patients based on the risk stratification, intermediate and the poor risk. We see here the more response rate and possibly more improvement in the progression-free survival and the overall survival in this population. The response rate may not be the great, but there is a more improvement in the PFS and the overall survival. And this happens in many clinical scenario, especially when the immune checkpoint inhibitors are being utilized. Next slide, please. Next slide. Yeah. So keynote 4 to 6, we all are now familiar. This has been talked in the various platforms. That is the Pembro plus axitinib. Probably it's the standard of care presently, at least for the affordable group of the patient and the intermediate and the high risk patients. And it has been compared with the sunitinib. And the important point which we forget many times when we discuss these kind of the trials, that in all these trials, the sunitinib had been the 4 weeks versus 2 week schedule. Presently, we maximum time use it 2/1 schedule. So what is the difference? Probably nobody knows, but yes, compared to the conventional schedule of the sunitinib, these all trials has shown the favorable improvement in the primary endpoint as well as in the secondary endpoints. Next slide, please. Next slide. Yeah. So this is how, again, you can see the improvement in the overall survival at the various parameters, at the various points. PFS improvement is also there. The graphs start separating in the very beginning, and that remains continuously. Next slide, please. And you can see that this improvement, especially I would like to bring your attention here, that yes, there are now more than 10% CR and the response rate goes to the tune of the 70%. Now that means almost more than 2/3 of the patients, they are going to respond, and you can counsel your patient in the clinic accordingly. So this sort of the response is something like the chemosensitivity response rate in the metastatic breast cancer. Next slide, please. So in the intermediate poor risk group of the patients, they start separating in the very beginning, maybe in the first 1 or 2 cycles, you start having the response, and it continued to have the widening of the or the separation of the two curves between the sunitinib versus this combination of the drugs. Next slide, please. And that is the new trial and nivolumab plus cabozantinib, because cabozantinib single agent is now also approved in the first line and in the subsequent line of the treatment also. So obviously we can expect more response rate and more PFS improvement in this particular sort of the combination. And here the nivo is the 240 milligram, not the 3 milligram per kg body weight, plus cabozantinib with the lower dose, that is the 40 milligram, and conventional dose of the sunitinib has been compared. Next slide, please. Next, please. Next slide, please.
Yes, just taking time.
So can we go to the next slide, please? So I will be focusing myself on only on those trials which are drugs presently available in India. Can we go to the next slide, please? Next slide, please. So atezolizumab plus bevacizumab is another way to treat the metastatic RCC in the first line. The stratification here was done based on the PD-L1 positivity also. It was the atezolizumab 1.2 gram plus beva 15 milligram every 3 weeks versus sunitinib. Next slide, please. And here we can see that those patients who are the PD-L1 positive, these patients showed the improvement in the PFS as well as in the improvement in the overall survival compared to the intent to treat population in general. Next slide, please. So if by chance you have the biopsy of the patient and the PD-L1 is done because of any region, you can think of adding the atezolizumab plus bevacizumab in certain group of the patient. And Javelin trial, again, the first line being approved, in the subsequent line also approved, depending on that what you have given previously. And because avelumab presently from the Pfizer is not available in India, so probably this combination in our setup is not so important. Next slide, please. Next slide, please. Next, please. So another trial probably which is coming on the horizon, and I'm quite optimistic that this is again going to change the landscape or the algorithm of the treatment of the metastatic RCC in the first line. That is the based on the lenvatinib. So they have compared the lenva plus mTOR inhibitor or lenva plus pembrolizumab versus sunitinib in the first line. So interesting will be the scenario to see whether the lenvatinib plus everolimus, which is being applied presently in the second line, that will be better, or lenva plus pembrolizumab, that is the immune checkpoint inhibitor, will be better compared to the sunitinib, and how these two arms will be behaving, and how this trial will be moving further for our first line treatment of the group of the patient. Next slide, please. So the various trials which are on the radar, that is based on the various combination, that is the lenva plus pembro versus sunitinib versus len plus everolimus. Just I told you. Another is a cabozantinib plus nivo plus ipi, that is the 3 drugs combination, or various other trials in the adjuvant setup, that is the single agent immune checkpoint inhibitor versus 2 drugs, immune plus IO plus IO in the high risk patient. So these results will be coming very soon, and probably they are also going to change the scenario in the adjuvant high risk patients. Next slide, please. So as on today, when we are entering the 2021, the scenario remains almost same compared to the last year. That is, for the favorable risk of the group of the patient, you can opt for sunitinib or pazopanib for that matter. Still, axitinib plus pembro will give you the better or will have the edge over the pazopanib plus or sunitinib. But they are there. All three are the valid options. Other recommended regimes for this particular will be the IO plus IO or XC plus avelumab if available. And active surveillance may also be thought of because of the comorbidity or other reasons. Axitinib, yes, we know that this has also been studied in the first line, but presently not being used much. For the poor intermediaries, certainly it need to be the combination of the drugs, maybe the IO plus IO, or my favorite remains the axitinib plus pembrolizumab because of toxicity profile and because of my own confidence in this combination. Yes, you can still use for the sunitinib or pazopanib if you think that the cost is the matter for the patient. And similarly, the axitinib remains one of the choice. High dose interleukin we don't talk much about today because the drug is not available most of the time because of the toxicity profile, our experience, and to have the suitable patient. But yes, this is the one which gives you the durable response or maybe the complete remission also. Next slide, please. So when you consider the first line treatment in the RCC clear cell, consider the debulking nephrectomy discussed with the patient, as Dr. Dipanjan Pada just told us. The pros and cons of the nephrectomy should be discussed, especially when you are talking about the immune checkpoint inhibitors in the combination in the first line. Multiple good systemic therapy options for metastatic RCC with no obvious clear choice in some cases are available. Good risk patients and those with a favorable intermediate risk still may have the survival, or you may opt for the single agent TKI like sunitinib or pazopanib for them. Availability of the newer IO combination or the TKI combination, yes, they have created the much paradigm shift in the management of the RCC in the first line. Risk stratification is the most important thing to opt for the treatment. And with this, I would like to thank all of you for patiently listening.
Thank you very much, Dr. Naresh, for an excellent overview of the first line treatment. And now we come to second line and beyond by Dr. Manish Singhal, who will be highlighting when the tumor progresses, then what do we do next in the second line and beyond that.
Hi, sir. Thank you very much. I'll just share my screen. I hope the screen is visible to everybody. Is the screen visible?
Yes, sir.
Yes, go ahead.
Yeah. So, am I audible and the screen is visible, right?
Yes,
Yep.
sir.
Yeah, thank you very much. So, I think we have had two great talks. One is about the role of nephrectomy, which is quite talked about still. I think the favorable risk still stands for nephrectomy, whereas intermediate and poor risk may may defer their nephrectomy. And we have had a wonderful talk about the first line treatment of metastatic RCC, and we know that the era has come of IO-IO or IO-TKI, which offers not only better results, but also very prolonged survivals. And at least in the IO-IO arm, that is the Nivo-EP combination, the checkmate study has shown that at 42 months of follow-up, you have almost 35% patients who have never progressed. So perhaps we can't really use the term of cure, but perhaps these patients are getting cured because they're progression free at 42 months of follow-up, which is the largest or the longest follow-up data that we have from the checkmate study. Unfortunately, the keynote 426, which seems to be better tolerated, relatively better tolerated as compared to IO-IO, does not have as long follow-up as the checkmate study. And so it really needs to stick at 35% of PFS at 42 months, the keynote 426. So, but it seems that we are more tuned towards using exitinib pembrolizumab as compared to IO-IO, because there is definitely some fear factor about using ipilimumab of managing the toxicity of IO-related drugs. So coming to second line and beyond treatment options, so we know that most of these patients will progress unless until somebody has received an IO-TKI or IO-IO combination. Still the majority would relapse at some point in time. So we really need to be aware of what next to give these patients and what next to offer these patients based on their primary treatment that they have received in the first line. So we know that VEGF TKI remains active, or the VEGF pathway remains active in these patients. And so this is an important pathway to be targeted by various drugs. And we are aware of the various trial data about exitinib, sorafenib. And the other pathway which is activated in these particular tumors is everolimus, the mTOR pathway, wherein everolimus offers you some advantage. And of course, if the patient has not received an IO drug in the first line, then IO immuno-oncology drugs is also an important option to be given. So, so the options that are listed in the NCCN guidelines are basically Nivo-EP combination or a nivolumab alone combination based on the checkmate 2-5 study, the cabozantinib, which is based on the Meteor study, which offers a progression-free survival advantage. And of course, exitinib in the yesteryears when all these agents were not available, then exitinib used to be the drug of choice. And we definitely have some data about lenvatinib in combination with everolimus. So I said that we are spoiled by choices. So there are a lot of choices to be used, and we need to understand what sequence to be used. And this is the data that we used to have some years back. So sorafenib, everolimus, exitinib, temsirolimus were the basic drugs available to us. And the overall response rates in these particular drugs used to be in the range of 10 to 15%, although exitinib did show some improved overall response rates reaching around 20%, but the median progression-free survival was in the range of 4 to 6 months. This is what we could best offer in patients of metastatic RCC clear cell in second line. Cabozantinib was one drug which had additional pathways targeted, such as the MET pathway and the VEGF-R2 pathway. And this is one drug which was approved based on the Meteor study, wherein there was a head-to-head comparison between everolimus 10 milligram once a day versus 60 milligram once a day of cabozantinib, with PFS as the primary endpoint based on an independent radiological review. It did show that the progression-free survival improved from 3.8 months to 7.4 months with a hazard ratio of 0.48, which was statistically significant, and a response rate of reaching almost 20-25% as pitted against everolimus, which was less than 10%. The overall survival data did show that there is an OS benefit of around from 16.5 months to 21.5 months, and the hazard ratio was 0.66. So this was a successful study, and that is the reason it finds itself as category 1 in the NCCN guidelines. So these are the Kaplan-Meier curves for your visual impact, and we know that the overall response rate did improve with the addition of cabozantinib. Patients, those patients who have been, so the other option that was there is we have the data coming from temsirolimus, sorafenib. But if you look at most of these data, the progression-free survival is sitting at around 4 months to 5 months, whereas cabozantinib does offer a progression-free survival reaching almost 9.1 months, especially patients who have been exposed to only a VEGF TKI in the first line. So 9.1 months is a good progression-free survival to look at. So coming to nivolumab, we were all excited about nivolumab based on the Checkmate 025 study. Again, it was pitted against everolimus, and the primary endpoint was overall survival. We know that mostly in IO drugs, OS becomes the primary endpoint instead of progression-free survival. And the key secondary endpoint were overall response rate and PFS. The OS was met. The primary, the median overall survival was 25 months versus 19.6 months in everolimus, and the hazard ratio was 0.76. As expected, the PFS was not very different between the two arms, but the overall response rate was 25%, which was quite impressive. As a matter of fact, we all have treated such patients, and we know that some of these patients are still on the drug 2 years, 3 years, 4 years in follow-up, and they are doing quite well. Also, some of these patients, they just continue to respond, as is shown in this particular the swimmer's plot, where some patients are still continuing to receive the treatment even at 2 years of follow-up. So put together, I think these are the options of treatment. We know that placebo doesn't work, although axitinib reaches about 4 to 5 months of median progression-free survival. Cabozantinib is at 7.4 months, and we have a progression-free survival of around 4.5, 4.6 months even with nivolumab. But those patients who do respond, they seem to be responding for a long duration of time. And that is the reason nivolumab does become one of the treatment options. These are the overall survival plots, and you can see that the overall survival seems to be the best with nivolumab. So with these options, lenvatinib plus everolimus combination comes in, and we need to look at that. What does this combination offers? So lenvatinib is used in the dose of 18 milligram once a day with everolimus 5 milligram once a day. And this was pitted against lenvatinib full dose, that is 25 milligram OD, which is the thyroid dose, versus everolimus 10 milligram OD, which was the record data dose of 10 milligram. With the median, with the primary endpoint of progression-free survival and the secondary endpoint of overall response rate and overall survival. And these patients could have received first-line VEGF TKI therapy and should have progressed on their first-line VEGF TKI therapy. So these are the patient dispositions, and they are very well matched between the two arms. About 40% patients had poor risk disease, and the sites of metastasis were bone, liver, or lung, which was also quite equally matched between the two arms. So coming to the progression-free survival, the PFS was an astounding 14.6 months as against 5.5 months with a hazard ratio of 0.4. I don't think that we have ever achieved a PFS of 14.6 months with any other combination, be it nivolumab, be it axitinib, be it any other drug. Lenvatinib combination in the independent review also showed that it is around 12.8 months with a very similar hazard ratio of 0.45, which was 0.4 earlier, 0.45 now, and 5.6 months with everolimus alone. And if you look at the overall response rate were again quite astounding, 43%. Just to recapitulate, with cabozantinib, it was around 21%. It was 25% with nivolumab. It is sitting at 43% with lenvatinib plus everolimus, and it was around 6% with everolimus alone. And these are the waterfall plots for your visual inspection. And the overall response rate seems to be, there were a few CRs, but mostly it was basically partial remissions. And the duration of response is again around 13 months versus 8.5 months. So overall response rate seems to be better off with this combination. And this is the overall survival curves. Again, the overall survival is around 25 months as against 15.4 months with an impressive hazard ratio of 0.59. And this is very similar to the overall survival in the cabozantinib study, as also in the nivolumab study. So almost the ballpark figure has been reached of 25 months of overall survival. Toxicities, of course, there are toxicities, but if you look at grade 4 toxicities, they were very less, and mostly these toxicities were diarrhea, fatigue, and hypertension. So these toxicities were there. There were no major toxicity related deaths, and they were quite similar between the two arms. So in conclusion, the response outcomes with this particular combination of lenvatinib and everolimus seems to be quite reconciling, with overall response rates reaching almost 40% plus, with progression-free survival in excess of 1 year, and an overall survival in excess of 2 years. So I think this is quite reconciling in itself, and this is definitely a combination which one would look at. There's a lot of talk about nivo-AP combination, especially in patients who have been exposed to IO alone drug or an IO VEGF TKI. They can be re-challenged with nivo-AP combination. So there has been a few publications in JCO about re-challenging these patients with the nivo-AP combination with about 23% response rates, and also leading to some increase in response rate and some long-term survivors. So this data has already been published in JCO, and there's definite data about re-challenging these patients with the nivo-AP combination. That means introducing a CTLA-4 inhibitor. So the choice of treatment after disease progression will depend on what particular therapy one has received in the first line. So if somebody has received a nivo-AP combination, then we know that IO drug is out, and you may choose between cabozantinib, axitinib, or lenvatinib everolimus combination. Of course, there is ease of using this combination because this is freely available, although one can talk about using axitinib also. A patient who has received a VEGF TKI and immunotherapy, that which will mostly be a combination of pembrolizumab or axitinib, or perhaps looking at the Checkmate 9 ER study with nivo and cabozantinib, then one is left with either using cabozantinib or an everolimus alone or a lenvatinib everolimus combination. So this combination stands true for a patient who has been exposed to immunotherapy and VEGF TKI. A patient who has been exposed to only VEGF-directed TKI monotherapy, one would prefer to use nivolumab because there is a chance of long-term remission. Although lenvatinib everolimus data also appears to be quite promising from the PFS and OS benefit on the median scale, but we know that long-term survivors are achievable with an IO drug. So definitely most patients would prefer an IO drug. Patients who have been exposed to VEGF TKI monotherapy and are somehow not eligible for immunotherapy because of cost or autoimmune disorders, perhaps lenvatinib everolimus does offer a clear advantage over here, with the PFS reaching almost in excess of 1 year and overall survival reaching in excess of 2 years. So this is a proposed sequencing option, and I think it's quite clear that we are spoiled by choices. So we have got a lot of options now. Axitinib, pembrolizumab in a favorable risk group, followed by cabozantinib, perhaps followed in third line with lenvatinib everolimus combination. One can shift this because cabozantinib is not readily available. In an intermediate poor risk, axitinib, pembrolizumab or a nivo-AP combination followed by lenvatinib everolimus, or cabozantinib followed by lenvatinib everolimus or axitinib, something like that. So these are various proposed options. Not that one has to really follow them very strictly, but I think this risk stratification is very important, and choosing the right therapy and whatever the patient is eligible, both economically and otherwise. So there are a lot of interesting studies. I know that this space is only going to become more and more complicated and more busy, and as more and more data is going to come up. But with that, I thank you for your kind attention, and over to the organizers.
Thank you very much, Dr. Manish, for an excellent talk overview of second line and beyond. And I would request Dr. Sekho to take it over and Dr. Shyam Agarwal to continue with the panel discussion, please. Dr. Shyam Agarwal.
So thank you. Dr. Manish, you are there?
I'm there, sir. I'm there.
So, very interesting. If you can show that last algorithm, which does not include sunitinib and pazopanib in first line, or of any of your, a good risk, intermediate risk.
No, sunitinib is very much there, sir.
No, it is not there. You show that slide. Show me that slide, if you can. You say cabozantinib and the combination of exitinib and
not in favorable. Sunitinib
right?
is there. I think that's a
No. Hold on. So what I'm saying is that
No, it's not there.
that this man, the guy who has made that slide, I mean, he's taking out the TKIs, which is what we are still going to be using for maybe many more years to come. So that's very interesting. As you rightly said, we are spoiled by choices.
yeah.
So I think with this comment, we can go on to the panel discussion. So we have, I think we can see Sachin and Dr. Kumardeep. Let me just. So that's a simple case. The idea is to just thrash it out. I think all the speakers, Naresh, Manish, and Dipanjan will stay back. Dr. Amit Verma, I did see. Are you there, Dr. Amit?
Yes, sir, I am there.
Yeah, welcome. And Dr. Harshvardhan and Dr. JB Sharma, they joined?
No, sir.
Okay, so I think let us go to the case. It's a very simple case provided by the Eisai people. The idea is to have a discussion, maybe 20 minutes of discussion on the subject, which we all are aware. And I think Manish and Dipanjan and Naresh have really brought out the point. So this is a patient, 63-year-old male with gross hematuria, with flank pain, 8.5 centimeter tumor, LDH high, but normal hemoglobin and normal calcium. Next, please. So can we, this is the options which we have, nephrectomy alone, sunitinib, interferon, or a combination or surgery followed by chemo. So Sachin, what is your thought process on adjuvant sunitinib in patients with RCC? I think that is the question here, which we would like to discuss.
Sir, so far not used personally, and was not too much convinced, but maybe I would look at this data more now to whether to use this. But this patient is not metastatic. This is clear.
At the moment, no. Yeah. So we're going to progress to metastasis in the next few slides.
Of course, yeah. So, sir, I'm personally not prescribing adjuvant sunitinib as of now.
So, any of us, Manish, have you used adjuvant sunitinib on a young patient with, nodal involvement or maybe IVC, tumor thrombus? So what are your thoughts on those couple of trials which they appeared, on sunitinib adjuvant setting? Or even the other one?
I would not say that this is a very common scenario that we get to see patients who have been resected and are eligible for sunitinib. But I would say that yes, we have proposed and some patients have agreed to take it with whatever deficiency is there in the data. But so I have written maybe about 2 patients in the last 1 year adjuvant sunitinib.
Right.
That's basically the abstract study which showed a DFS of around 1 year benefit, 5.5 years versus 6.5 years, 1 year benefit in the disease-free survival. And that is the abstract study, which was an NEJM publication. Having said that, it is still category 2B because people are not very convinced, because other studies such as the PROSPER and the PROPER and the other sunitinib study, they didn't show any benefit, and the very latest sorafenib study has also not shown any benefit.
Is there any OS data still out of this?
Only DFS data is there.
Yeah, only DFS, yeah.
So if I believe, sir, out of 12 or 9 or 12 study, only that extract showed a benefit, that is also PFS. So as of now, we are using only cases which is not exactly adjuvant, but there we think there is a high risk of recurrence. Like I have one patient not on sunitinib, but because she could not afford sunitinib, where it is IVC tumor thrombus, and after taking out the thrombus, the surgeon told me, I believe there is a part of thrombus which remained attached to the vena cava wall. I could not remove it. So I don't know, though radiologically we couldn't see much, but we gave that patient, and the patient ultimately recovered after 2 years.
So that becomes a residual disease kind of a situation.
Yes. So only in those cases where there is, radiologically you cannot see the tumor, but surgeons believe that there is high chance of residual disease. There we are definitely using it, but otherwise I don't think the data really suggest, considering there is significant toxicity also.
Dr.
And
Kumar,
sir, I would like to. So we have used in certain situations where we find certain small lung query metastasis, so doubtful lung metastasis, and a lot of times we find some lesions in the lung which we are not able to exactly pinpoint whether they are metastatic or not.
Problem is, for how long would you use it?
Yeah,
The study used it only for 1 year.
For 1 year, yeah. So then we keep
But
on
in
following.
this situation, if you stop it after 1 year, the patient is going to progress anyway.
We are basically following these sort of cases. We all see these cases. I mean, my practice, I don't know, I think Manish also, we follow them closely. If there is a progression, then I personally plan to do an FNSC to confirm it and then start. But otherwise, the problem what Manish says, how long would you give? What would be your end point?
So adjuvant sunitinib is only for 1 year.
1 year.
Correct. Yeah.
Yes.
So, with doubtful cases, I mean, as I think you, to my mind, correctly said, and I think Naresh may also agree, that may be asymptomatic 4, 5, 6 nodules, which are so tiny to even biopsy. A close observation may be the right approach, I guess.
Yes, sir.
I do not believe in the adjuvant sunitinib or any TKI for that matter. And I believe that the 1 year of the TKI, whatever the PF, this recurrence-free or disease-free survival we have, probably in the present era where there are subsequent second-line, third-line options are available, is not going to impact anything on the outcome of the patients.
So you're not convinced. Dr. Kumardeep, have you used sunitinib in the adjuvant setting?
No, sir. No, sir. I'm yet to get a patient of this kind to prescribe adjuvant sunitinib.
Okay, Dr. Sekho, I mean, your thoughts, have you had a patient who had, 5 nodes positive, all removed, but then, adjuvant setting? What do you think? Is Dr. Sekho there? Okay, so I think we can move on to the next slide then. So it's a, kind of a debate there. A lot of people it needs to be, I guess, individualized. So in a young patient with high tumor load, maybe you can discuss with the patient and the family, and it could be an individualized decision. So this patient underwent right radical nephrectomy. It's a clear cell with some sarcomatoid features. 9 months later, fatigue and dry cough, PFS 70%. CT chest you can see the lung nodules there, and the periphery also. And these are the lab parameters: calcium 9.2, platelets like normal, WBC is 12,400 with a neutrophil count of 9,000, hemoglobin 10.5. So this is after a gap of, I think 9 months, they said, yeah. So Dr. Dipanjan, Dr. Panda, maybe he's not there. So again,
yes, sir. Yes, I'm here.
So
I'm here, sir. Tell me.
So now what do you want to do? Can we go to the previous slide? Yeah.
Yes,
Dr. Dipanjan,
right, radical. Sir, I'm looking at it. Just
there are
multiple. Sir, yes. I've seen.
More than 5. Okay, more than 5.
Sir,
it's not oligometastatic. So let's be clear. Don't count. Diagnosis or notice.
You are a thought reader. You are a thought reader. You are a thought reader.
Yeah, I know. So question is,
sir,
diagnosis.
I will radiological, it seems to be lung metastasis, and it is I think too tiny for biopsy. So if FNSC is possible, I will do an FNSC to confirm it, or otherwise I will discuss it with the patient to start him on a TKI.
Okay.
My choice is
Dr. Kumardeep. Okay, want FNSC and start the treatment. Dr. Kumardeep, FNSC or no FNSC?
Definitely, I'll try for FNSC.
Definitely.
If it is feasible. Okay. If it is feasible, then.
Okay, Naresh.
In this scenario, it's very clear. It's a central lesion, it's small lesions. Probably I will not try to poke the patient. Will convince the patient, and probably FNAC is not going to give me the much material for NGS or so. So probably FNAC will not be my preferred way to start the treatment. And already I have the histopathology because sarcomatoid features.
Sachin?
Sir, there is subpleural disease also I can see, and it's less than 1 year of the diagnosis. I think it's pretty clear this patient has lung metastasis. I will not prefer doing an FNA, but if only the patient wants it to be proven, then of course I can go ahead and prove it. And so I can see a lot of risk under IMDC criteria. So less than 1 year, Karnofsky PS is also less, HB is low, and neutrophil count is higher. So a lot of factors are there already.
Manish?
So this goes to a higher risk category.
Manish?
I think, sir, there is a sarcomatoid feature also.
Yeah.
So
sarcomatoid features.
No. You see, you have the advantage of 5 people who have spoken, and a couple of them are saying yes, couple of them say no regarding the FNAC. So,
it is at least intermediate or high risk by the IMDC or MSKCC scoring, and it is a sarcomatoid. So I'll go with Nivo-EP combination.
No, we're not talking of treatment. We're talking of FNAC. We're still stuck at
FNAC. I think I'm quite convinced there's no need of FNAC.
No FNAC.
Is there any differential diagnosis in the mind?
I don't know. I mean, we don't have a tissue diagnostic confirmation here. You never know what it is.
So if I may say that I as a policy prefer to confirm with FNAC of all the recurrence, even if radiologically it seems quite. That is a policy I use.
We get your mind. We get Kumar Deep Datta's mind. And of course, Naresh categorically says no need to do an FNAC. Sachin, I believe, wants to do it, but he's scared of the risk of perforation or whatever pneumothorax. And Manish is non-committal. So Dr. Amit is there. Dr. Amit Verma. So Amit.
Yes, sir.
Somebody said I would love to do it, but I will not get the tissue for NGS. So if you want to do NGS, what are your thoughts?
I think the answer is very clear that we can choose between the TKI or the IO with plus TKI, and so I don't need to do NGS as of now.
Okay, so as of now, NGS is not the need.
Not a routine plan, but if somebody gets ask me a question whether we have to choose between TKI and IO plus TKI, and can you predict what is going to be the outcome and which is better? Though theoretically we have the data favoring the IO plus TKI, but at the molecular level we do have some signatures to predict whether the TKI is superior to IO. So we can use that if somebody asks categorically, but otherwise
Dr. Amit, if I do a biopsy and demonstrate PDL1 to be like 40-50%, so will that be helpful in decision?
Yes, it will be definitely helpful. If I do an NGS, and if I come across a PBRM1 mutation, which is quite common, up to 40% in RCC,
which
that
one?
favors
Can you say that again, please? We are not
PBRM1.
So remember that.
PBRM1 is a mutation which is very common in RCC after the VHL gene, and this is seen up to 30 to 40% of RCC. And this mutation favors the response to sunitinib over IO. On the other hand, if patient is found to have a BAP1 mutation, BAP, then the patient may favor IO over sunitinib. So if somebody wants to use that molecular signature to define the treatment, it can be done. And this has been well reported in the IM Passion 150 in the subset analysis, that the PBRM1 selection favors the sunitinib arm actually.
So I would like to invite the comments of the clinicians on this subject of PBRM and the PDL1 positivity and the selection of the first line agents.
Sir, I would like to ask Dr. Amit, So this is possible in the nephrectomy specimen as well, or do we need a fresh biopsy or tissue here?
It can be done. It can be done in the primary sample as well.
Any
Because,
timeline you would suggest? Suppose this patient relapsed after say 2 years or 3 years. Even then, it is possible on the primary specimen.
So because this is a treatment naive patient, so there is no treatment pressure. So I can assume that there is no much, you can say, change in the clonal evolution because no treatment has been given post nephrectomy. Had it been a post treatment scenario, then I would prefer to do a repeat biopsy if the treatment time has gone more than a year actually.
So, this is bringing us to a point whether we should do molecular signatures and PDL1 before starting treatment for first line metastatic RCC. Manish.
Not ready for prime time, sir.
Right. So I think
so. There was a study in this very ISMO meeting,
okay,
and that was called as the BioNIC study. The BioNIC study defined by the molecular signature VEGF upregulated, IO upregulated, cold tumors. So there were 4 categories, and they defined that those patients who are IO upregulated do not read the IO-IO combination. They are good enough with with nivolumab alone, and those who are TKI or the VEGF upregulated tumors, they do well with sunitinib. You don't need to introduce IO drug. But I think all these are ready for research, but not ready for prime time on clinical use.
Dr. Kumardeep, you have any comment on this subject, please? Of doing the molecular signatures or even a simple PDL1 to decide between IO versus, TKI. Naresh, Dr. Naresh, are you there?
Yeah, sir, if atezolizumab plus beva is in my mind to give the patient, then probably PDL1 stratification will be required. If the PDL1 negative, then probably I will not opt for the VEGF inhibitor plus atezolizumab combination.
Sir,
that is the only thing presently I can say.
Sir, in Pembro plus exitinib trial, there was no role of PDL1, right? So there it is irrespective of whatever the PDL1 value is, you can use that.
Yes, yes.
Yeah.
But now question is regarding the sarcomatoid feature.
So the question is very simple. Molecular signature, yes or no?
Right.
At the
moment, I think there is no clarity.
I think we need to learn this and, at some point of time, yeah.
Yeah, we are learning. So Dr. Amit says that TBRM is a particular gene which we should be looking forward to. The BioNIC study says that there are tumors which are upregulated on the immune side versus the VEGF side. But all that is in the phase of development at this point in time. Maybe 2-3 years down the line when we can.
Sir, Manish का patient अगर Nivo plus IFI afford कर लेगा, वो molecular signature भी करा लेगा sir.
Hold on, let's not. Please, those are all, let's get science here at the moment. So, yeah, please. We understand that.
Seriously, sir, I think sarcomatoid feature, Nivo plus EP is a good, but it is also having significant.
No, Dipanjan, the point is, your patient or Manish's patient or my patient has a lot of money, but the data is not there to support doing those.
Signature is not, because if I am putting the patient double IO, we know that EP can have serious side effect also. So I think, but in sarcomatoid RCC, they have a better response rate. So I think if I have to discuss, and if I have the tissue, I agree that in that case, maybe a FNST is less.
Commercial, where will you send the sample? If you have to send a sample, where will you send
I will ask Amit.
So I have a suggestion here because the patient had sarcomatoid histology to begin with at the primary. So the patient already is a poor prognostic scenario. So we would have given adjuvant treatment irrespective of the staging and all, actually. That is my personal opinion. And regarding the NGS, NGS can be done in the primary, even in the adjuvant setting where we can predict the aggressive behavior. As the patient have recovered within 9 months, and we could have done something better for this patient. Regarding getting it done anywhere, so gene panel assays are available in India.
Well, it has to be, Amit, it has to be an authenticated, validated platform. We can't just do it, based on what data.
So, if I just like to quote this, this has been discussed for a couple of years now. almost like PBRM1 is quite well established biomarker. We are not
If
using
it
it
is
to
so
make
very well
decisions.
established, why doesn't it appear in the NCCN guideline or any other guideline?
So you just Google this marker in RCC and you will find a lot of literature. It takes a lot of time
I'm not
because
denying
doing a biomarker
I'm not denying the
is not
literature.
easy.
I'm not denying the literature.
So
But
doing a biomarker,
whether it is a
making a companion
biomarker which is
diagnostics.
ready for prime time and use in clinics for every day in and day
Yes,
out, I
fair
don't
enough.
think so.
Yeah.
We have
Yeah.
evidence to suggest.
No, that is okay. So normally whenever we talk about a companion diagnostics, we also have to take into account the feasibility of doing companion diagnostics. We cannot just make a biomarker and say it is available. So doing an IGS in all RCCs it's totally not recommended, and we do not promote that. But if this biomarker is easily doable, and maybe in the near future, I think it will become a companion diagnostic very soon. Actually, that
I
is
think
my
there
I
is a
think because
learning
its
curve to
commercial
everything,
availability is
and it will take some time before we learn how to use these biomarkers and what drugs are to be incorporated. So a lot of times we have biomarkers, we don't have drugs, and we have drugs, we don't have biomarkers. So there is a mismatch. Everything is not moving simultaneously. So let's say in lung cancer, we had so much to do now, and go back 15 years, we were hardly doing anything, giving same chemotherapy to everybody. So we have less number of RCC patients as compared to lung cancer, and this things are still evolving. So let's there would be some hit and trial going on a lot of times, and there is a learning curve attached to it.
I think this was an interesting discussion, but at the moment, no testing is required before deciding what agent needs to be given.
So your voice is not very. The volume is low. Maybe.
Okay, so at the moment,
Yeah.
there is no testing required other than the confirmation of the metastatic disease. No PDL1 testing is required. No NGS is required to decide which agent is to be given. It is only maybe the decision on the, the risk scoring, which helps you decide what is to be given to a given patient. So this patient.
I have a suggestion here, sir, because we always consider RCC to be clear cell carcinoma and we take a call accordingly.
Okay.
But we have to dwell in the histologies, whether it is papillary, where we see MET amplification, cabozantinib will be a better choice. And sometimes we have the other histologies, the rare histologies, where the other genes can dominate. So we have to also look.
I think here it is written, it is sarcomatoid clear cell variant.
No,
In this case,
that is okay. I'm just making a general statement. I'm just making a general statement here that whenever we are making a call, histology has to be taken into account besides the clear cell carcinoma.
Of course, of course.
So can we go to the next slide, please? I think we need to move on. Yeah. So I think this has all been discussed. Let's go to the patient. Yeah. Next. So here this patient was started on sunitinib because, I mean, ideally, I guess, given the scenario of sarcomatoid and, as they said, it is intermediate risk, a pembro plus a TKI like exitinib should have been the first line. But I believe the cost is a huge factor. And this patient was given sunitinib in the standard dosing with good response. However, the patient had grade 2 fatigue and leukopenia, thrombocytopenia, and had Fund syndrome at 5 months. So this patient, next slide, please. I think we need to go to the. So how would you proceed in a patient who is responding but increasing side effects? So anybody can take this.
So here first I will try to attempt a 2/1 schedule. There is a 2 weeks on, 1 week off. If that manages, it's a good. If even that is not helping in this scenario, then maybe 37.5 will be the dose for the sunitinib.
Okay, either reduce the dose or go to 2/1.
Yeah.
I think that is fairly acceptable, Sachin.
Yes, sir. Absolutely same. I would do the same. Yeah.
So I think not much of a debate there. Go ahead, next slide. So I think it was withdrawn in this patient for 6 months, and then new lung pleural metastasis and regrowth of the existing metastasis appeared. Next slide, please. So this was restarted in the same dose. 1 year later, disease progressed, and some new nodules appeared in the lungs. and patient has good performance status but no disease-related symptoms. Next. So what would be your choice of treatment who's been given sunitinib for progressive disease with good performance status? So that is the question. Dipanjan. Dipanjan. Next slide, please.
Dipanjan, you need to unmute yourself.
Hey, sorry, I was in car. I just sir, can you just repeat the question? I have not seen. I was
second line therapy after sunitinib.
Patient has failed sunitinib and has progressed in the lungs and nodes and all, and with good performance status.
So it depends on the financial condition of the patient. I'll discuss, but I usually try if the patient is financially okay, then my choice is IO in a second line. Otherwise, I prefer to use everolimus.
Everolimus alone.
Along with lenvatinib now.
Can I make a comment here?
Sure.
Dr. Shyam Agarwal, sir,
Yes,
your
sir.
patient both time had the poor tolerance to the sunitinib.
Yeah.
So in this case, I will not opt for the Lenva plus everolimus combination. I don't think that this patient is going to tolerate. So my choice straightforward will be single agent nivolumab.
मैं तो दे रहा था सर श्याम सर मान नहीं रहा है ना
There are two. Hold on, yeah, come on. There are two scenarios. Either patient can afford nivolumab or the patient cannot afford nivolumab. So what to do for an unaffording patient? Naresh, if the patient cannot afford nivolumab, then what?
If patient cannot afford the nivolumab, then yes, single agent everolimus is one of the choice. And maybe the single agent lenvatinib, maybe off the record generic, because we are talking about the Eisai expert group. So I will say that
Eisai does give a good patient support program, sir. So that's not a problem. Sometimes we decrease the dose of Lenva, but contrary to Lenva is actually pretty well tolerated.
No, in this case, I would like to point it out that the patient had the progression, but the poor tolerance. So sunitinib to lenvatinib, I believe as far as the toxicities are concerned, the combination of the Lenva plus everolimus, whatever the dose you reduce, it's not so easy to give to the patient.
Even exitinib is generic now. I think exitinib is definitely an option. And especially with individualized dosing of exitinib, which was a Lancet Oncology publication, that actually you can actually increase the dose of exitinib to 10 milligram BD. And if you are able to attempt an individualization of exitinib dose, you can actually get a very good progression-free survival of around 9.2.
Somehow my personal experience with exitinib is not great, but I agree with that. That is definitely an option. But I find I am using lenvatinib for HCC. And I'm pretty happy with the side effects.
Dose is double. The dose is...
Yeah, dose is higher, but I would like to interject here.
The highest dose is in thyroid cancer, and I have used 24 milligram in medullary thyroid cancer also. It's not always dose dependent. Okay. So people, especially actually HCC, I can tell you, if you have a patient has to do poorly, whether you give him 8 milligram or 24 milligram.
is a fairly better tolerated drug.
Yeah,
it is
Manish and Dipanjan. So we are comparing here with sunitinib, which is I think a much more toxic drug than than
so it is the everolimus I'm more afraid of, honestly, giving full dose.
But in combination, the dose is 5 mg everolimus, which is a better tolerated
so
dose.
I have used, I think, in 2-3 patients, Lenva plus everolimus, and I am not very unhappy with the side effect. Honestly,
even I have used it with my limited use. I can say the toxicity was not a problem actually.
So what is the dose of lenvatinib in the combination? 18.
18, sir.
18, sir. 18.
Yeah.
Kumardeep, you have not spoken. Any thoughts? Dr. Kumardeep Datta.
He was also traveling. Where is he?
Sir, may I?
Helmet.
Yes, doctor. So, the question is, cabozantinib is still also there in the second line. So, are there any markers for cabozantinib?
MET is one of the markers which is seen in the tumor NGS actually. If you find it, you can try it. If you want to make the outcome better beyond sunitinib. Otherwise, I think it will be all the same. But at this juncture, I would like to have a biopsy to see whether the clear cell is dominating or the sarcomatoid is dominating. If it is sarcomatoid which is dominating, then lenvatinib, which does have a PD additional thing as compared to the other TKI, may be advantageous, and also everolimus can be advantageous as compared to the sunitinib. If it is just the clear cell dominated metastasis, then the discussion remains the same.
No. I need to get it clear. So if the sarcomatoid component is high, then you are saying lenvatinib.
Yeah, and the rationale is that the lenvatinib have additional PDGFR inhibiting effect, which other TKI does not have, and sarcomatoid component is rich in PDGFR actually. And
I thought if there is a sarcomatoid component, you lean towards IO than VEGF inhibition. What about Sachin?
I don't think
Sachin
so.
or Manish or
Sir, if you read the checkmate study, the checkmate 214 IO combination, in the sarcomatoid component, they registered a response rate in excess of 70% with a very major number of patients, about maybe 20%. I'm not very sure, but I can look up at the data and tell you. The CR rate is also very high in sarcomatoid.
Right. So that is what I also had the.
So
I agree with Manish. I think IO combination is the only one.
In the discussion part. You need to read the discussion part of the NEGM publication.
Right, yeah, I agree. If there is a significant sarcomatoid component, I think Nivo plus EP is the one which has shown the best response. If it is not available, then you can use the Pembro plus the Lenva option. But I think the best response has shown to Nivo plus EP, although the toxicity was also significant.
I totally agree, but the issue was that the patient cannot afford IO actually. Otherwise, IO plus TKI is definitely a better option. But in case if you want to make a switch from TKI to TKI, that was the suggestion I was trying to make.
Yes, I agree. Definitely. Absolutely.
Yeah.
Okay, so I think the conclusion is that if somebody has a sarcomatoid component in the second line situation, then an IO combination should be preferred. If somebody cannot afford that, then lenvatinib combination is all right. Okay, right? Is that correct?
But Dr. Agarwal, I have a small query. The percentage of sarcomatoid component is not A. Suppose somebody have a say 10% sarcomatoid, somebody have a 60% sarcomatoid. So I don't remember any cutoff of choosing.
More than 50%.
Anybody? Amit, any thoughts there? 10%, 30%?
No, sir.
No, I don't remember. I honestly don't remember the study. Manish can remember. Manish remembers the trials like palm of his hand.
So anybody who has more than 30% sarcomatoid component is said to be sarcomatoid dominant.
Okay. 30%. Amit, you said
yes, sir.
हमको second line में अभी biopsy करना चाहिए.
Yes, sir.
एक तो biopsy के अंदर आपने NGS वो आपने MET देख लिया. आप बोले कि अगर MET होगा तो then we can go for Cabo.
PDGFR होगा तो lenvatinib.
हाँ जी.
If PDGFR is there, then lenvatinib.
And if you get PTEN mutation is also very common in RCC. So if that's the case, then you have to go with everolimus.
P10 के लिए. Okay.
Yes, sir.
And then of course you perhaps will do the PDL1 and TMB as.
वो तो but natural है, वो तो करना ही है.
Soft like that. So so you should go to all the hospitals now and start guiding us on what should we do on the NGS report. You can't get time to Mac Hospital, yaar.
Sir, आज ही सुबह मैंने अमित को फोन किया. I only called Amit.
Sir, he's a very sought after guy. We approach him so often.
I'm serious.
Especially if some patient comes with a NGS report which you can't make head and tail of it, then you have to give him a call. Yaar, ye kiska kya kare?
So today only I asked him about an MSI report. Even that is so confusing. It just makes you mad.
I think Amit is now used to getting calls from other oncology colleagues. Reports.
Thank you very much. Thank you very much for remembering me. Thank you very much for remembering me. It makes me
your life actually if you don't get an NGS done in the first place.
So Naresh, you have any points? Are you there?
No, sir. No more point in discussion, sir.
So do you have a next slide? I think we have covered most of the things. Basically 4 options to my mind, Nivo, I mean, or an IO, because that is the latest, if somebody can afford, and still the second IO is not available. Second option is lenvatinib and everolimus combination. Third is exitinib, and fourth is cabozantinib as and when it becomes available. So one needs to make a choice after sunitinib failure in patients with RCC, and then I mean, you can do the NGS or your MSI testing and PDL1 testing to fine tune this indication of either of these 4 or 5 options which you have in patients with metastatic RCC. And then of course the financial issue comes into being. So I think it's opening up, and I think a lot of combinations were discussed where Cabo is being combined with IO, and that is an interesting combination which may be very, very impressive. Who knows? But then in the first line, I think IO spares you the TKIs, which can be used in the second line. If that is something, if somebody can tolerate and afford, would make a difference, maybe in the long-term outcome of these patients with metastatic RCC. But yes, 3 years, 40% patients, I mean, really amazing data, which is kind of not seen in the last 5 years, is emerging and giving a lot of hope. And Dr. Julka and Dr. Sekho are there to make their final comment, please.
Dr. Sekho, is he there? Dr. Sekho, are you there? I think...
sir, I just lost the connection, I guess.
So
Dr. Julka can make the closing. Thank you very much, everybody, for the interactive session. Yeah.
I think it was
Thanks, sir.
And we have learned a lot about TKI, IO combinations, and all the new modalities which are coming. And the most important, which Amit was also highlighting, the IM Motion 151 study, in which the Atizo plus bevacizumab versus sunitinib. Now, this PDR, mutations are being seen, and in sarcomatoid component, we see less of PDRN mutation. And we have AMPK activity. We have other molecular features which we see. I think Amit would be able to highlight those features. And we have yet to start doing, this NGS for RCC. So we have had a very good discussion. And I think with this, we close the session. Thank you very much for this session.
Thank you, sir.
Thank you, everybody.
Thank you. Thank you, sir.
Thank you, Eisai, for the
Thank you, sir.
Thanks, Eisai.
Happy New Year to everybody.
Happy New Year.
Thank you. Thank you very much, everyone, and wishing you a very happy New Year, all. Thank you very much, Dr. Shyam Agarwal, sir, for conceiving this meeting, and thank you very much. It was an honor to have Dr. Julka and Dr. Sekho with us, and thank you very much for all the speakers and the panelists for making it a wonderful scientific event. Happy New Year and good night once again.
I thought you would make it a 1st January program with all the party at next year. Next year, there is always a next year.
मतलब वाइन भेजनी पड़नी थी इनको उसके लिए.
हाँ सर.
Thank you. Thanks.
Thank you. Thank you, everyone. Thank you.